Welcome to this presentation. This will be a lecture on dementia. We'll be covering the following. We'll be looking at the definition of dementia, a description of the clinical features of dementia, behavioral and psychological symptoms of dementia, the different types of dementia. We'll be looking at the key features of Alzheimer's disease, vascular dementia, fronto-temporal dementia, dementia with Lewy bodies, and mild cognitive impairment. We'll be finishing with a set of 5 self-assessment MCQs based on the lecture. Some information about myself. I'm a consultant psychiatrist based in Chennai, which is a city in southern India. I have worked for many years in the United Kingdom. So dementia is a term that is used to refer to a group of heterogeneous neurodegenerative disorders that typically present with decline in memory, decline in other cognitive abilities, decline in emotional control, and decline in social behavior. To make a diagnosis of dementia, the symptoms should be present consistently for at least 6 months. The diagnosis of dementia should not be made when the patient is confused or delirious. So in other words, you should make a diagnosis of dementia in clear consciousness. Collateral information should be obtained from relatives or carers, and it is very important to establish a deterioration from a previous higher level of functioning. The memory decline in dementia is typically progressive. It initially affects the learning of new information. As the disease progresses, the patient is unable to recall even previously learned information. In advanced stages, the patient may be unable to recognize even close relatives such as children or spouse, and in the final stages, they may not even be able to say who they themselves are. Similarly, the decline in other cognitive abilities also is progressive. Initially, the patient finds it unable to do relatively complicated tasks that they were able to do previously. As the disease progresses, they need assistance even for relatively simple tasks. And in advanced stages, the patient is unable to do any cognitive activity even with assistance. Dementia by definition is irreversible. However, in a small proportion, reversible conditions can mimic symptoms of dementia. So these need to be ruled out before making a diagnosis of dementia. I have listed some of those conditions. Severe depression can also mimic symptoms of dementia, so-called depressive pseudo-dementia. In these patients, effective treatment of depression will reverse the cognitive impairment. However, it should also be noted that a history of depression is a risk factor for future dementia. BPSD stands for Behavioral and Psychological Symptoms of Dementia. They occur in up to 90% of patients with dementia at some stage of their illness. They occur in Alzheimer's disease and in other types of dementia also. They cause considerable distress to patients and carers. In contrast to cognitive impairment that is usually irreversible, BPSD can be treated effectively, thus improving the quality of life of both patients and their caregivers. In this slide, I have listed the common behavioral symptoms which occur as part of BPSD. And in this slide, I have listed the common psychological symptoms. What are the different types of dementia? Dementia in Alzheimer's disease or Alzheimer's dementia is the most common type of dementia, accounting for about 2/3 of all cases. Vascular dementia, dementia with Lewy bodies, fronto-temporal dementia, and dementia can also occur in other disorders such as Parkinson's disease, HIV/AIDS, Huntington's disease, and CJD. The incidence of Alzheimer's disease increases with age. Studies in Western countries have suggested rates of about 5% of Alzheimer's disease in those above the age of 65 and 25% in those above the age 85 years. The risk is higher in those with a family history of Alzheimer's disease. The risk is higher in females. The definite diagnosis of Alzheimer's disease can only be made by post-mortem neuropathological findings. However, with a thorough assessment and investigations, one can make a fairly confident clinical diagnosis of Alzheimer's disease. Alzheimer's disease can be divided into late onset and early onset types. The age of 65 years being the demarcating line. The late onset type accounts for more than 95% of cases. The early onset variety is more severe and more rapidly progressive. In this slide, I have listed the potential risk factors for Alzheimer's disease. And in this slide I have listed the potential protective factors for Alzheimer's disease. Genetic factors play an important role in both early onset and late onset Alzheimer's disease. There is an increased risk of Alzheimer's disease in those with a family history. As far as the late onset Alzheimer's disease is concerned, the inheritance is not in a typical dominant or recessive Mendelian fashion. One gene has been consistently implicated in late onset Alzheimer's disease, and that is the ApoE4 or apolipoprotein E4 gene. So this gene has an increased prevalence among patients with Alzheimer's disease. However, the prevalence varies among patients in different countries, with the highest prevalence in Northern Europe and the lowest in Asia. It accounts for about 25% of the risk of Alzheimer's disease. Heterozygous or single ApoE4 allele doubles the risk of Alzheimer's disease, whereas homozygous ApoE4 alleles increase the risk fivefold. However, ApoE4 is neither necessary nor sufficient to cause Alzheimer's disease. Three genes have been implicated in early onset Alzheimer's disease. These are the APP or amyloid precursor protein gene, presenilin 1 and presenilin 2 genes. Mutations of these genes seem to be inherited in an autosomal dominant manner, and hundreds of such mutations have been identified. The effect of the genetic mutations is to increase amyloid beta production, which leads to the extracellular deposition of amyloid. Neuropathological changes in Alzheimer's disease include extracellular amyloid plaques, which consist of deposits of amyloid beta peptide, and intracellular neurofibrillary tangles, which are deposits of hyperphosphorylated tau protein. In addition, non-specific changes due to oxidative stress and inflammation that occur in Alzheimer's disease include widespread loss of neurons and synapses. This is a pictorial representation of amyloid plaques and neurofibrillary tangles. On the left side you see a normal neuron, and on the right side the Alzheimer's disease showing extracellular amyloid plaques and intracellular neurofibrillary tangles. And this is a histopathology slide showing the same changes, plaques and tangles. There is a significant association between Down syndrome and Alzheimer's disease. Down syndrome is due to trisomy of chromosome 21. That is, there are three chromosome 21 instead of 2. The gene that codes for amyloid precursor protein is located on chromosome 21. So in Down syndrome, because there is an extra chromosome 21, more amyloid precursor protein is produced. Almost all patients with Down syndrome exhibit amyloid plaques and neurofibrillary tangles by the age of 40. Clinical symptoms of dementia may take a few more years to appear. As life expectancy of Down syndrome patients increases because of better medical management of their physical complications, more associated Alzheimer's disease in these patients is likely to manifest. So this is the spectral karyotype in Down syndrome. As you can see, there are 3 chromosome 21 instead of the usual 2. Cognitive assessment in dementia is extremely important. The most commonly used test is the Mini Mental State Examination, or MMSE. It tests different aspects of cognition and gives a score out of a total of 30. And there are a few other tests that are also used, and I have listed 2 of those. And this is the Mini Mental State Examination. If you want, you can pause and go through the test items. Different studies use different gradings of severity based on the Mini Mental State score, and I have given one example. On average, Mini Mental State examination scores decline by 3 to 4 points every year. However, there is considerable individual variation. So some patients might deteriorate faster, while other patients might decline much slower. In this slide, I have listed the key distinguishing features between dementia and delirium. So if you want, you can pause and note down the differences. This slide lists the first line blood tests that are usually done in a patient presenting with symptoms of dementia. Imaging plays an important role in the assessment of a patient with dementia. Most patients would require either a CT scan or an MRI scan. The main features of Alzheimer's disease evident in a brain scan would be generalized cortical atrophy and ventricular enlargement. This would also help to identify potentially treatable causes like normal pressure hydrocephalus, subdural hematoma, and tumors. MRI has a better resolution than CT and it's also better at identifying subcortical vascular changes. There are certain other tests that can be done depending on the need. I have listed some of those tests here. Functional neuroimaging like SPECT and PET scan may have a role in selected cases, but these tests are still mainly restricted to research settings. There have been some recent developments in the neuroimaging of dementia. A type of PET scan using Pittsburgh compound B has been shown to be useful in Alzheimer's disease. This compound gets concentrated in areas of amyloid deposition. DAT scan, which is a type of SPECT scan, has been used in Parkinson's disease, and it has also been shown to be useful in suspected cases of dementia with Lewy bodies. This assesses the function of the dopamine transporter and the integrity of the nigrostriatal pathway. This is the MRI scan of a patient with Alzheimer's disease. On the left you see an age-matched healthy control, and compared to the healthy control's brain, the brain of the patient with Alzheimer's disease shows significant cortical atrophy and ventricular enlargement. And this slide shows 3 successive MRIs done on the same patient over the course of that person's illness, and the magnified area refers to the hippocampus, and as you can see, as the illness progresses, the hippocampus, which is very important for memory, gradually atrophies. And this is a PET scan. On the left hand side you see a normal brain. So in a PET scan, areas that are red indicate higher activity, and as you can see, as the illness progresses, in early Alzheimer's the red areas become fewer, and in advanced Alzheimer's, that is the image on the right, there are hardly any areas that show high metabolic activity. Biomarkers may have a role in Alzheimer's disease. These are not diagnostic, but they may be supportive evidence in cases where there is clinical doubt. Genetic testing, ApoE4 for late onset Alzheimer's disease, and amyloid precursor protein gene or presenilin genes for early onset Alzheimer's disease, and plasma level of amyloid beta protein and CSF levels of amyloid beta protein and tau proteins may be useful. It should be remembered that the sensitivity of these markers is only modest, thereby limiting their clinical utility. The mainstay of the pharmacotherapy of Alzheimer's disease are the cholinesterase inhibitors. These are licensed for mild to moderate Alzheimer's disease. And the examples are donepezil, rivastigmine and galantamine. These drugs inhibit the enzyme cholinesterase, which breaks down acetylcholine. Acetylcholine is important for learning and memory, and it is postulated that ACH is deficient in Alzheimer's disease. These drugs, by inhibiting the breakdown of acetylcholine, help to prolong the activity of acetylcholine. The other drug that is also licensed for Alzheimer's disease is memantine. This is an NMDA receptor antagonist. This is licensed only for severe Alzheimer's disease. It acts by reducing the activity of glutamate, which has neurotoxic effects, and it is postulated that the activity of glutamate is raised in Alzheimer's disease. With respect to the behavioral and psychological symptoms of dementia, the whole range of psychotropics can be used if appropriate. It should be remembered that antipsychotics should be used with caution in patients with dementia, because there is a potential risk of increased cerebrovascular accidents, and it appears that the mortality of dementia patients who receive antipsychotics is increased. And it's also important to try and avoid anticholinergic medication in patients with dementia and drugs with anticholinergic activity like tricyclic antidepressants, because these can worsen the cognitive impairment and can also predispose to confusion. The general principles of management of patients with Alzheimer's disease. The patient should be managed in a safe, calm, comfortable and predictable environment. Regular social interaction with carers, family and friends should be encouraged. The patient should be encouraged to take part in activities that they enjoy. Adequate sleep, regular physical exercise and mental exercises can also help. There are numerous non-pharmacological treatments that have been tried in dementia. I am mentioning three of those: cognitive stimulation, reality orientation, and validation therapy. We will briefly look at each. Cognitive stimulation therapy is indicated for mild to moderate dementia. The aim is to stimulate and engage people with dementia. Formal CST is done according to a treatment manual, and it is done once or twice a week for several weeks, usually in a group format. And examples of some activities that are done during these sessions include discussions on a certain topic, word games, music, baking, etc. A Cochrane systematic review has found benefit from CST in improving cognitive functioning and also quality of life. The purpose of reality orientation is to help orient the patient to time, place, and person. These are frequently mentioned in conversations with the patient to help reduce disorientation. At a very basic level, it is useful to regularly discuss current events with the patient. Some practical suggestions in implementing reality orientation: displaying a prominent calendar and clock in the patient's room, having labels on rooms, cupboards, drawers, suitcases, etc. Try to maintain consistent daily schedules so that the patient does not become confused. Encourage the patient to read the newspaper and to watch television news. Have a board which gives today's date, day of the week, month, year, season, today's mean menu, etc. In validation therapy, the principle is to validate or agree with what a patient with dementia is saying, even though you know that it is factually wrong. The aim is to not confront the patient that they are wrong or to be dismissive. For example, let us assume that a patient is adamant that he wants to go out, as he says that he has an important meeting at his workplace. In reality, the patient is 85 years old with moderate dementia and he last worked 20 years ago. In validation therapy, you will initially agree with the patient that he indeed has an important meeting at his workplace, but then you try to steer the conversation to a neutral topic. For example, let us have a cup of coffee before you go to work, or let us have a walk in the garden. And by that time, the patient's mind is likely to get distracted and he is no longer likely to be adamant or insistent that he wants to go out. Alzheimer's disease is irreversible, progressive, but the rate of deterioration varies from patient to patient. Early onset Alzheimer's disease tends to progress faster. As illness advances, the patient will need more and more assistance. Death usually occurs within 10 years of onset. The cause of death is usually an infection, most commonly bronchopneumonia. We now move on to vascular dementia. Most studies indicate that this is the second most common cause of dementia. This is potentially preventable by managing risk factors. The main risk factors are stroke and transient ischemic attacks. Other risk factors include smoking, hypertension, diabetes, coronary artery disease, atrial fibrillation, dyslipidemia, etc. This used to be called multi-infarct dementia. Vascular dementia often coexists with Alzheimer's disease, because if you remember from the list of potential risk factors for Alzheimer's disease, that included a number of vascular risk factors also. The main mechanisms by which vascular dementia occur include multiple small cortical infarcts, a single large infarct secondary to thrombosis or hemorrhage that resulted in a stroke. Small vessel disease. Vascular dementia is more common in men. You may recall that Alzheimer's disease is more common in females. It usually starts between the ages of 60 and 75. The deterioration in vascular dementia is typically stepwise after each TAA or vascular insult. This is in contrast to the gradually progressive decline that is seen in Alzheimer's disease. There is no treatment that can reverse the cognitive impairment once it has occurred. Primary prevention of strokes and TAAs and secondary prevention of further strokes and TAAs by adequately managing the vascular risk factors and by encouraging healthy diet, regular exercise and smoking cessation. This is an MRI of a vascular dementia, and the typical finding is white matter hyperintensities. Another MRI showing the same changes. We now move on to fronto-temporal dementia. This used to be called Pick's disease. This is the second most common cause of dementia in those under the age of 65. Depending on the presentation, it is subdivided into three types. The most common type being the behavioral variant, which accounts for 60% of cases, with mainly frontal lobe involvement affecting personality, executive functioning, and emotional control. In this slide, I have highlighted some key differences that might help distinguish between Alzheimer's disease and frontotemporal dementia. If you want, you can pause and note down the points. Family history is an important risk factor for frontotemporal dementia. Histopathologically, this disorder is characterized by intracellular spherical inclusions called thick bodies or balloon cells which contain tau protein. Many mutations have been identified, with the commonest being in the MAPT and PGRN genes. Frontotemporal dementia is occasionally associated with amyotrophic lateral sclerosis or motor neuron disease. There is no licensed treatment for frontotemporal dementia. Psychotropics can be used judiciously in the management of behavior problems. Like other types of dementia, this is also a gradually progressive illness. And the life expectancy is usually 6 to 8 years after diagnosis. The right picture is an MRI from a patient with frontotemporal dementia. Compared to the normal brain on the left, the patient with frontotemporal dementia has significant cortical atrophy in the frontal region. So this slide shows PET scans from a patient with Alzheimer's disease and a patient with frontotemporal dementia. In Alzheimer's disease, the hypometabolism is mainly in the parietal and temporal lobes. The frontal lobe is not that much affected, whereas in frontotemporal dementia, the parietal lobe shows reasonably good activity, but it's the frontal lobe which shows very little metabolism. We now move on to dementia with Lewy bodies. In this condition, in addition to some cognitive decline, the presentation includes fluctuations in attention and alertness, recurrent vivid visual hallucinations early in the illness, Parkinsonian features, and other features include REM sleep behavior disorder, severe neuroleptic sensitivity, repeated falls or syncope or other autonomic symptoms. Family history does not seem to be an important risk factor in dementia with Lewy bodies. Medial temporal atrophy is also not a prominent feature in DLB, as memory impairment is not prominent. Main neuropathological finding is the presence of Lewy bodies, which are intracytoplasmic inclusion bodies containing alpha-synuclein protein. The same Lewy bodies are also seen in Parkinson's disease. Abnormal DAT scan, which is a type of SPECT scan, supports a diagnosis of dementia with Lewy bodies. Occipital hypoperfusion or hypometabolism are seen in SPECT and PET in patients with DLB. This is a pictorial representation of Lewy body. DLB, like other types of dementia, is progressive. There are no licensed treatments, but options may include cholinesterase inhibitors and memantine. It is wise to avoid antipsychotics in DLB, as neuroleptic sensitivity is a major risk, particularly with older antipsychotics. Levodopa may not help the motor symptoms in DLB as much as it does in Parkinson's disease. DLB stands for dementia with Lewy bodies. LBD stands for Lewy body dementia. These terms are usually used synonymously but are not identical. DLB is actually a subgroup of LBD. LBD includes both DLB and Parkinson's disease dementia. In this slide, I have listed the key differences between DLB and PDD, Parkinson's disease dementia. You can pause and note down the differences. Mild cognitive impairment, or MCI, is an intermediate state between normal aging and dementia. It affects about 20% of the population above the age of 65. More than a third of these patients with MCI go on to develop dementia within the next 3 years. And based on the main cognitive function that is affected, MCI can also be subdivided. MCI may be more common in men. Dementia as a whole is, however, more common in women. MCI may be considered analogous to the at-risk mental state that may precede a first episode psychosis. So just as only a proportion of patients with ARMS go on to develop a full-blown psychosis, similarly only some with MCI go on to develop dementia while others do not. Also, just as ARMS does not precede first episode psychosis in every patient who develops a psychosis, similarly MCI does not precede dementia in every patient who develops dementia. So before we finish, we will look at 5 multiple choice questions. Question 1. Which of the following is true regarding genetics of Alzheimer's disease? If you want, you can pause now, go through the options and select your choice. The correct answer is A. Genetic factors are important for both early onset and late onset Alzheimer's disease. Question 2. Which of the following favors a diagnosis of fronto-temporal dementia rather than dementia with Lewy bodies? If you want, you can pause, go through the options and select your choice. And the correct answer is C. Onset before the age of 65 years. The other 3 options favor dementia with Lewy bodies. Question 3. DAT scan, which may be useful in dementia with Lewy bodies and Parkinson's disease, is a type of which of the following scans? Is it a structural MRI, a functional MRI, a PET scan, or a SPECT scan? The correct answer is D. SPECT scan. So DAT scan is a type of SPECT scan. Question 4. What is the likely type of dementia shown by this brain MRI scan? If you want, you can pause and select your option. The answer is A. Alzheimer's disease. This brain MRI shows significant generalized cortical atrophy, which is the hallmark of Alzheimer's disease. Cortical atrophy is also seen in frontotemporal dementia, but it is restricted to the frontal and temporal regions. Cortical atrophy is not a major feature of vascular dementia or dementia with Lewy bodies. Question 5. Which of the following is not a cholinesterase inhibitor? You can pause and select your choice. The correct answer is C. Memantine. This is a NMDA receptor antagonist. And that brings us to the end of this presentation. Thank you for watching. Hope you found the information useful.